Okay. Good morning, guys. Good afternoon. Welcome to the class. So today we are going to talk about a surgery quiz. So all of you are ready? Just give me a thumbs up who are able to hear me. Okay. Good morning, guys. Good afternoon. If you can hear me and see me properly, just give me a thumbs up. Okay. So do I have few people over here? Right. So, okay. So let us start by talking about today's session. So today we'll be talking about a surgery quiz and we'll be covering few things in this, okay? So we'll be talking about 14 MCQs basically today. Okay. So just give me a thumbs up if you guys can hear me properly. So, the first question for today is a 40-year-old male patient who is a chronic smoker came to the hospital with a history of a pain on walking. You advise angiography, and this is the image which you see. So, what is the patient suffering from? What is the most probable diagnosis in this particular patient? So, I don't think we have many viewers today, but like whoever is there, can you please try to answer? What is the answer to this particular question? Well, the answer to this particular question is in fact right. So answer to this particular question is anybody? Okay. Well, the answer to this particular question is Berger's disease. Now, why is it a Berger's disease? Because what is happening in here? Can you see this? This is what you call as a characteristic lesion of a Berger's disease. So what is this? This is a corkscrew collateral. What is this? This is a corkscrew collaterals. And corkscrew collaterals are a characteristic feature of Berger's disease. And even if you kind of see in this particular history scenario, so here you have a young male who is less than 50 years of age who is a chronic smoker and he's coming to you with a pain on walking, which is indicative of intermittent claudication. Now, you advise an angiography, and what you get on angiography is this corkscrew collaterals. So the given history along with the angiographic finding, all this is very much suggestive of that the patient is suffering from Berger's disease. Okay, so what is the answer to this particular patient question? The answer is Berger's disease. Okay, so let us move on to the next question. So okay, so reimplantation time of the lower limb is up to. So how much is the reimplantation time of the lower limb? Okay, so if at all there is, a lower limb or an extremity which has been amputated, till how much time can we reimplant it? So this is basically a repeat question, a memory-based question, not a very kind of logical question. So what is the answer to this particular question? Can you tell me? So answer to this particular question is in fact 6 years. So reimplantation time of the lower limb is up to 6 years. Now if I would have changed the question and if I would have asked you how much is the reimplantation time of finger or a digits, okay? So if I change the question and if I ask you what is the reimplantation time for digits, or let's say a finger which has been amputated, what is the answer to this particular question? So I can see a couple of you are there online, so please try to answer. What is the answer? The options remain the same. What is the answer? So I can see around 6 to 7 of you are online and watching this at this moment. So can you please try to answer what is the reimplantation time for the digits or the fingers? Okay. Well guys, the answer to this particular question is 8 years. Okay, so for the 8 years, it is the reimplantation time for the digits or the fingers. For the upper limb or the extremities, it is around 6 years. Now, understand one thing, whenever you have a amputated digit or a finger or something, how do you transport it? Do you put directly into the ice? So well, no, you put it in a plastic bag, and this plastic bag is basically filled with a saline, and then you keep this plastic bag in a container which is filled of ice. The finger should not come in direct contact with the ice. Okay, so the finger is kept in a fluid, most probably a saline, and this is kept in a plastic bag. This plastic bag is placed in a container, and in the container what do we have? We have a ice. So this is how you transport any amputated finger or whatever to a particular location. So if you want to transport amputated finger from the site of accident to, let's say, a hospital or a casualty, how do you transport it? You put in a finger into a plastic bag containing the normal saline. You put this bag inside the container which contains the ice, and then you transport this container. Okay, so this is about this particular question, reimplantation time. Now let us move on to the next question. the classification system used for intra-abdominal aortic aneurysm. So for the intra-abdominal aortic aneurysm, what is the classification system which we use? Is it modified Crawford classification, Stanford classification, D. Bakey's, or all of the above are for the intra-abdominal thing? What is the answer to this particular question, guys? Can you tell me what is the answer to this particular question? Okay, so answer to this particular question is, can I hear it from you? What is the answer to this particular question? Just try to attempt. Even if you like make a mistake in here, that's completely fine. But yeah, can you tell me what is the answer to this particular question? Okay, so well, the answer is not D. Okay, so Shraddha, yes, thanks for answering. It is not D actually. So that is basically a trick question which I was forcing you to attempt. So please understand here, modified Crawford classification, it is a classification system for intra-abdominal aortic aneurysm. But what about the Stanford and the D. Bakey? These are not for the intra-abdominal aortic aneurysm. These are for the aortic dissection. Okay, these are for the aortic dissection. So now can you appreciate this? So this is basically for the aortic dissecting aneurysm. It may be in the thoracic cavity, it may be in the abdominal cavity, but modified Crawford, it is basically for the intra-abdominal aortic aneurysm. Now, Shraddha, can you tell me which is the most common site of intra-abdominal aortic aneurysm? Which is the most common site of this intra-abdominal aortic aneurysm? A very important MCQ has been asked a couple of times. So what is the most common site of intra-abdominal aortic aneurysm? So the most common site of intra-abdominal aortic aneurysm is, in fact, can you tell me? It is infrarenal abdominal aorta. Okay. So what is infrarenal abdominal aorta? So after the aorta has given its renal arteries, after giving the renal arteries and before bifurcating into the external and internal iliac, this particular portion is the site where the maximum intra-abdominal aortic aneurysms arise. So what is the most common site of intra-abdominal aortic aneurysm? It is infrarenal abdominal kind of aorta. Okay, so yes, this is about the classification system for intra-abdominal aortic aneurysms. Now, let us move on to the next particular question and let us talk about the occurrence of the hyperthyroidism following the administration of supplemental iodine. So it is basically trying to ask you iodine-induced hyperthyroidism. Okay, what is it known as? Is it a George-Wesdorf effect? Is it a Wolff-Chekhov effect? What is the answer to this particular question? Can anybody try to attempt it? So what is the answer? So Shraddha is up with the answer, George-Wesdorf effect. Very good. So this is in fact the George-Wesdorf effect. So very simple. Iodine-induced hyperthyroidism is the George-Wesdorf effect, and iodine-induced hypothyroidism, that is Wolff-Chekhov effect. Now some students have difficulty in remembering this. So how I tell them to remember is Wolff-Chekhov. So Wolff-Chekhov sounds like Wolff cutoff. So Wolff-Chekhov is Wolff cutoff, and this is basically iodine-induced hypothyroidism. Okay. So yeah, if you are someone who gets messed up between George-Wesdorf and Wolff-Chekhov, you can try to remember it like this. Wolff-Chekhov is nothing but like a Wolff cutoff, and Wolff cutoff is nothing but iodine-induced hypothyroidism. Okay. Okay. What about this thyrotoxicosis factitia? So this is basically a factitious disorder. It is kind of a psychiatric disorder, factitious disorder. So what used to happen in this? The patient feels good to come to the hospital and get treated or something. So what the patient will try to do? It will try to emulate the symptoms. Okay. So what does the patient does? Patient injects the thyroid hormone into himself or herself and comes to you with the signs of hyperthyroidism. But this is basically a iatrogenic thing. The patient is kind of inducing the signs of hyperthyroidism into it. It is not because of some inherent causes. And this is what is called as a thyrotoxicosis factitia. Then dequervins thyroiditis is a benign condition of a thyroid. In this, what is happening? There is a inflammation, and there is this basically the infiltrative lesion of a thyroid. In this, the patient comes to you with hypothyroidism. Okay. So now let us move on to the next question. Thyroglossal cyst occasionally give rise to carcinoma. So which carcinoma is associated with thyroglossal cyst? Can you tell me? So Madhu and Shraddha, what is the answer to this particular question? Thyroglossal cyst. Most common malignancy arising from a long-standing thyroglossal cyst. What is the answer? Shraddha is saying papillary, Madhu is again saying papillary. Very good, guys. So the carcinoma arising from a long-standing thyroglossal cyst is in fact papillary. Okay, so it is an important thing. Now it is a very good MCQ, repeated MCQ, but yeah, it is kind of thing. Papillary is the most common thing. So Sanjana, it is not B, it is papillary. Okay, so please understand this. Okay, so thyroglossal cyst, what is it? It is basically embryological element in which the thyroglossal duct fails to degenerate. What is the most common site? It is subhyoid. What happens? Patient comes to you with a midline swelling, moves on deglutination and everything. How do you manage the patients? Surgery, you go for a cyst trunk operation. Okay, and what about the complication? It can get infected, it can lead to the thyroglossal fistula. And what about the another important complication? Malignancy can occur. Which malignancy? Long-standing thyroglossal cyst will give rise to papillary carcinoma of thyroid. Now another thing is in the follicular. So can you tell me which is the most common, one of the important predisposing factors for the middle follicular carcinoma of thyroid? So follicular carcinoma of thyroid can occur in a long-standing colloid goiter. So where it can occur? It can occur in the long-standing colloid goiter. Okay, so yes, follicular carcinoma can occur in a long-standing colloid goiter, and papillary carcinoma can occur in a long-standing thyroglossal cyst. So these two are important. Please remember this. Okay, right. Okay, now let us talk about the next particular question. So 10 horn sign. So 10 horn sign is a feature of what? Is it a feature of rectus muscle hematoma, acute pancreatitis, cholelocholithiasis, or acute pancreatitis? So what is the answer? So Shalini, Sanjana, Madhu, Shraddha, what is the answer to this particular question? 10 horn sign. Any vague memories about this? Okay, so well, the answer to this particular question is acute appendicitis. Now, this is not a very common clinical sign which you basically read about acute appendicitis, but what happens in this? If you pull the testes of the patient, what is 10 horn sign? In this, if you pull the testes of the patient develops pain in the right iliac fossa. So what is this 10 horn sign? In this, what is happening on pulling the testes of the patient, there is pain occurring on the right iliac fossa. So this is basically a 10 horn sign. Okay, right. Now, what about okay, so you have a obturator sign. Okay, so when will you get, what is obturator sign? So when will you get a pain in acute appendicitis on performing this? What is obturator sign? So in this, basically what is happening, there is a pain on flexion and the internal rotation. So if you get the pain in the right iliac fossa on flexing and internally rotating your legs, this is what is a positive obturator sign. Then what you have? You have a psoas sign. So what is this psoas sign? So if you get pain on flexion of the hip against resistance. So please understand, this is important. In the psoas sign, what do you get? You get a pain on flexion of the hip against resistance or hyperextension. Okay, so you can either perform flexion of the hip, so it is basically flexion against resistance, or it can be hyperextension. Okay, so if you get a flexion of the hip against resistance or a hyperextension, this is what is a positive psoas sign. Okay, so these are the few important signs of acute appendicitis. 10 horn sign is not very important, but it was asked once, so I just thought of taking it over here. Now, what is the shoe sign manual? Shoe sign manual is used in which surgery? Now, this is something which is a new question, might not be knowing, just try to attempt it. Okay, so I want you to attempt, guys. Okay, so Sanjana, Shraddha, what is the answer to this particular question? Shoe shine manual, it is used in which surgery? Okay, so can you tell me, shoe shine manual, this is used in which surgery? I'm waiting for your answer, guys. So Madhu is saying Nissen's fundoplication. Yes? Okay, so well, yes, Madhu is absolutely correct. It is in fact Nissen's fundoplication. Now, what is the shoe shine sign? I'll just tell you what is the shoe shine sign. So what is happening in here? This is basically a patient in which you are performing a Nissen's fundoplication. So what you do in Nissen's fundoplication, you take the fundus of the stomach, you wrap it around the lower end of the esophagus, and then you suture it to the other part. Now, when you're doing this, you have to make sure that all the structures which were attached to the fundus are free. So before, kind of suturing it to the other part, what you do is you grab hold of the fundus of the stomach through one end, and you grab hold of this part of the stomach through the other grasper, and you just move it like this over the esophagus. Now, this is some corollary to shining of the shoes which were performed in the old ages. So older times, what used to happen, there was a shoe kind of cobbler, and the people used to keep the shoes, and they used to use a cloth to shine the shoes by putting the cloth like this. Okay, so they used to rub the cloth over the shoes and they used to shine the shoes. Similar fashion, what you're doing here is you are rubbing or you're moving your fundus of the stomach along the esophagus, and that is why this is called as a shoe shine sign. Okay, so this is basically used in the Nissen's fundoplication when you go for Nissen's fundoplication in the via the laparoscopic approach. Okay, so this is about the shoe shine sign. Now let us talk about the next particular question. Now, spot diagnosis. Can you tell me what is the diagnosis in this particular patient? Okay, so is it periocular edema? Is it subcutaneous emphysema? It is a Pemberton sign, or it is a superior vena cava syndrome? So, Shraddha, what is the answer? Shraddha, Sanjana, what is the answer to this particular question? What is the answer, guys? What is the spot diagnosis in this particular patient? Is it periocular edema, subcutaneous emphysema, Pemberton sign, or superior vena cava syndrome? Anybody? Okay, so Shraddha is saying A, Manoj is saying B, okay, Madhu is saying D. Well, guys, this was asked recently in the MCI exam. Okay, now MCI exam, this question was asked a couple of years back, and as the exam governing body is the same, it is an important image now. Now, what is this? This is exactly right. It is subcutaneous emphysema. Okay, so Manoj is absolutely correct. This is basically a patient with subcutaneous emphysema. Now, why is it a subcutaneous emphysema? You can see these eyelids and everything, so they are all basically enlarged. So you will say how we can distinguish between periocular edema or something like that. So this is a characteristic feature, and most of the time what they will do is they might give you a clinical scenario attached to this. So they might give you that a patient was taken up for upper G endoscopy. After the upper G endoscopy, we noticed this particular finding in the patient. What is the diagnosis? The answer is subcutaneous emphysema. Okay, right. But even if the kind of clinical scenario is not given along with this, the answer to this is in fact subcutaneous emphysema. This is a very characteristic finding. Now another thing is X-ray of subcutaneous emphysema is very, very important. What you need to appreciate is the hazy appearance of the subcutaneous tissue. So you will get all the air kind of a thing, hazy appearance, blurred appearance in the subcutaneous tissue. That is again an X-ray which you should have a look at. I really don't have the X-ray at present, but yes, X-ray of subcutaneous emphysema, that is also very, very important. This particular image, the answer is subcutaneous emphysema. That is the answer. Okay. So Shalini, please make note. This is answer B, not D. Right. What is this Pemberton sign? So Pemberton sign is a feature of a retrosternal goiter. Where do you get it? You get it in a retrosternal goiter. So what is this? If you ask the patient to raise the arms above his ears, what will happen? The vessels will get compressed and the patient will develop a facial plethora. And this is basically a Pemberton sign positivity in the retrosternal goiter. Okay, right. What will you find in the superior vena cava syndrome? If at all there is a superior vena cava syndrome, you will find excessive collaterals over the chest. So you will get a dilated vessels on the veins over the chest, and these excessive collaterals will be suggesting of superior vena cava syndrome. Okay, now let us move on to the next question. Again, this is an important image, but yeah, ERCP finding has been shown here. So what is the diagnosis of this particular patient? So ERCP finding has been shown. What is the diagnosis? I want you to answer, guys. Okay. So is it okay? So what is this? Mucinous cystadenoma, serous cystadenoma, intrapapillary mucinous cystadenoma, and pseudocyst of pancreas. So all these are the cystic diseases of pancreas. Okay. So Madhu is up with the answer C. Okay. Anybody else? Okay. Mithu is saying D. Right? Anybody saying D? Okay. So Madhu, why C? What do you see in this particular ERCP image? Well, guys, Madhu is absolutely correct. Madhu, you are correct. Very nice. But can you tell me how did you come to a diagnosis of C? So Manoj, well, the answer is C. Okay, it's not A. So Madhu, can you just explain others how is the diagnosis C? What are you seeing in this particular patient? So you are seeing basically a fish mouth appearance. Okay. So what you are seeing? You are seeing a fish mouth appearance. So what is happening here? As soon as you cannulate this, pancreatic duct, what happens? A lot of mucin comes out through this particular duct. And this is very good, Madhu. So this is a fish mouth appearance. Very good. So this is a fish mouth appearance which you see in IPMN. Now what you need to understand is this. Pseudocyst of pancreas, this is a benign cystic disease of a pancreas, and MCN, serous cystadenoma, and IPMN, these are the malignant diseases, right? These have a malignant potential. Okay, right. So these are basically the tumors of the pancreatic cystic tumors of the pancreas. Now out of these IPMN, this is having the connection with the main pancreatic duct, And because it is having the connection with the main pancreatic duct, what happens? Whatever mucin is secreted by this tumor, it enters into the main pancreatic duct. And when it enters into the main pancreatic duct, what happens? If you try to cannulate, the mucus is coming out through the opening. And this is basically a characteristic fish mouth appearance which we get in IPMN. Is it a malignant? Yes. Okay, then what about the MCN, mucinous cystadenoma? This it doesn't. So mucinous cystadenoma and serous cystadenoma, they do not have connection to the main pancreatic duct. But mucinous cystadenoma is the one which has a malignant potential, and serous cystadenoma is the one which doesn't have a malignant potential. Okay. So these are a couple of points about mucinous cystic neoplasms. You need to remember it. They might not show you the image, but they might definitely ask you fish mouth appearance is seen in which. So answer is IPMN. Okay, right. So let us move on to the next question. By definition, a pigment stone. Okay, so we know that the gallbladder stones can be either cholesterol stones or it can be a pigment stone. In the pigment stone, what we have? We have a black stone and then we have a brown stone. Now what this is trying to ask you is, in the pigment stone, how much percentage of cholesterol is present? Okay, so how much percentage of cholesterol can be present in a pigment stone? So what is the definition of pigment stone? Less than how much cholesterol do you call it as a pigment stone? Okay, so it is again a repeat question, a memory based question, but a repeat question. I want you to answer, guys. Whoever is online, please answer. Try to attempt this particular question. Whatever comes to your mind, just try to answer. So well, Madhu, Shalini, Manoj, Shraddha, what is the answer? So Shraddha is saying C. Okay. Okay. Shalini is saying B. Madhu is saying B. Okay. Well, guys, the answer is in fact C. So it is less than 30%. So by definition, if you have less than 30% of the cholesterol in this particular any stone, you may call it as a pigment stone. Okay. So less than 30% of the cholesterol. It is a repeat question, guys. Okay. So please understand this, can be important. And it is a direct line from Levin-Bailey. Okay. So it is a direct line given in Levin-Bailey. Any stone having less than 30% of the cholesterol in it, it is a pigmented stone. So pigmented stone is a stone having less than 30% of the cholesterol content. Now, you all know the black stones, these are basically present in patients who are suffering from hemolysis. What about this brown stone? This is the stone which is present more in patients who have infection. So infection leads to brown stones. Why infection leads to brown stone? Because it has an enzyme beta glucuronidase. So it converts basically the bilirubin into the kind of the things by the action of the beta glucuronidase, and there is a ascending in leads to the cholangitis, and again it leads to the formation of a brown stone. Okay, now if they ask you which is the most common type of a gallbladder stone overall, so overall what is the most common type of the gallbladder stone? It is a cholesterol stone. If at all, mixed is not given in the option, that is fine. And if they ask you which is the most common type of gallstones in the Asian countries, then your answer becomes brown stone. So please understand, the most common type of gallbladder stone in the Asian countries, the answer is a brown stone. Okay, so right. So let us move on to the next particular question. A patient suffered from a road traffic accident, had a pelvic fracture. So the buzzwords in this are road traffic accident, patient developed a pelvic fracture. Good. Then the patient has no urge to pass the urine since 12 hours. Now, diet studies revealed the following finding. What is the diagnosis? Okay, so here what do we have? We have a patient who has suffered from a road traffic accident, having a pelvic fracture. Then he has no urge to pass the urine since 12 hours. And what they're trying to ask you, what is the diagnosis of this particular patient? So is it anterior urethral injury, posterior urethral injury, extraperitoneal bladder rupture, or an intraperitoneal bladder rupture? Image has been shown to you. So Shraddha, are you saying it's C? So anybody else? Are you sure, Shraddha, is it C? It is C? Okay, what is the answer to this particular, guys? Manu, Shreya, Shalini, what is the answer? Very simple question, basic question on posterior urethral injury. Okay, right now Manoj is also saying posterior urethral injury. Okay, what else? Okay, so good, guys. I am happy that you have already at least reached to the first step of the diagnosis. Okay, C. Okay, guys, well, the answer is extraperitoneal bladder rupture. Now, why is the answer extraperitoneal bladder rupture? What is given in the question? The question says that there is a patient who suffered from a road traffic accident. Patient has a pelvic fracture. Patient has no urge to pass the urine. Now, can I ask you, why do you get an urge to pass the urine? You get an urge to pass the urine because your bladder fills up. It distends and it tells your brain that, okay, go and pass the urine now. But what is happening in this particular patient? There is a bladder has ruptured. Okay, so bladder has ruptured, so whatever the urine is there, it is going out and the bladder is not getting distended. If the bladder is not getting distended, patient will have no urge to pass the urine. Did you get it? Okay, right. But what if the patient has a posterior urethral injury? I'm good that you try to correlate that the posterior urethral injury is also associated with the pelvic fracture. It is a good thing. But why the answer is not the posterior urethral injury? Because if the patient didn't have passed the urine for 12 hours, the patient would have got a palpable urinary bladder, and obviously patient would have a severe urge to pass the urine. But in this particular patient, the question has saying that no urge to pass the urine. If I just modify the question, if I say that the patient comes to you with a road traffic accident with a pelvic fracture and patient has not passed urine since last 6 years, and on palpation you have a urinary bladder which is palpable at the level of the umbilicus, then the answer would have been a posterior urethral injury. But for this particular question, the answer is extraperitoneal bladder rupture. I hope you could appreciate the difference in the diagnosis between extraperitoneal bladder rupture and posterior urethral injury. Okay, now let us move on to the next question. By performing this maneuver, like shown in the figure, if the bleeding from the liver does not stop. So this is a maneuver which you perform while managing a patient of a liver trauma. So while performing this maneuver, if the bleeding does not stop, the source of the bleeding is what? What is the source of the bleeding? Can you tell me what is the source of the bleeding? So Mithu is saying C. Okay. Anybody else? Manoj, Shalini saying C. Okay. Anybody else? Okay. Good. So you guys are saying it is C. So Madhu is saying A. Why A, Madhu? Okay. Well, the answer is in fact C. Okay. Very good. Right. Very good. Very good. Why hepatic artery, Yogesh? No, not at all. Not hepatic artery. The answer to this particular question is hepatic vein. Okay. Why? What is the maneuver which is shown here? It is a Pringles maneuver. So what do you do in the Pringles maneuver? You compress the hepatico-duodenal ligament. What do you compress? You compress hepatico-duodenal ligament. Now what is passing through this hepatico-duodenal ligament? We have portal triad which is passing through the hepatico-duodenal ligament. Okay, so if you compress this, what will happen? All the inflow to the liver should have stopped. So if you compress this, what will happen? The blood supply to the liver will be stopped. What is the constituents of this portal triad? So we have a portal triad in the hepatico-duodenal ligament. What are the constituents of the portal triad? It is a portal vein, it is a hepatic artery, and then you have a bile duct. So if you compress this hepatico-duodenal ligament, what should happen? The inflow should reduce. And if you compress this and if the bleeding stops, this indicates that the bleeding might be from the hepatic artery or the portal vein. But if I'm compressing this, if the bleeding continues, you have to know that this is because of bleeding from the hepatic vein. Are you understanding, guys? So please understand this. In this particular patient, the bleeding does not stop even after compressing the hepatico-duodenal ligament, and that is why the source of bleeding is hepatic vein. If the bleeding would have stopped, the answer would have been hepatic artery or the portal vein. Okay, I hope you understood this, guys. A very, very important topic. Pringles maneuver, very commonly done while managing a patient of hepatic trauma if at all you decide to go for a surgery. Right. Now, this is again a very important image. Where do you use this particular catheter? So do you use it for the bladder drainage, urethral catheterization, arterial thrombosis, or the venous thrombosis? Okay. So what is the answer to this particular patient question? So Yogesh, Madhu, Divya. What is the answer, guys? Anybody? Where do you use this particular catheter? So Sanjana is saying C. Okay, well, why Divya? Why D? Why venous thrombosis? Shraddha is saying C. Okay, well, guys, good. Most of you are saying C, and that is the correct answer. This is a correct answer. This is basically a Fogarty catheter. So Yogesh, no, again, it is not D. Okay, so what is this catheter? This is basically a Fogarty catheter. Okay, so what do you get? Like, where do you use it? You use it to remove the arterial thrombus. So how do you use it? So you use it similar to the use of Dormia baskets. So I'll just tell you how do you use it. So what do you have? Let's say you have a thrombus in the artery. So what you do? You pass this catheter in a deflated state. So you pass this catheter in a deflated state. So what do you have? You have a catheter which has been passed in a deflated state. Once the catheter reaches beyond this, what you do? You expand or you inflate the balloon. And then what you do? You pull this catheter out. Okay. So actually it's a catheter, it can even pass through the thrombus, you don't have to go beyond it. This is how you go for a DJ stenting, okay? Not a DJ stenting, a Dormia basket, okay? So here what you have to do, you have to pass through the thrombus, you have to go inside, you have to inflate the balloon, and once you are here, you have inflated the balloon, and you pull this out, the balloon will bring the thrombus along with it, okay? So this is the mechanism of acting of a Fogarty catheter. In a similar way, what works? Similar way works the Dormia basket, which you use in the ureteroscopic retrieval of the stone. Okay, now you guys got confused with the venous thrombosis. What is the treatment of choice for the venous thrombosis? Can you remove it? No, not really. So what you go for a pharmacological treatment. How do you treat it? You start the patient on LMWH and you start the patient on warfarin. When the warfarin levels reach it to the INR between 1.5 to 2.5, then you shift the patient from low molecular weight to the warfarin. Okay, so you start both simultaneously. Once the warfarin levels are monitored with the help of a PT-INR, if that level reaches between 1.5 to 2.5, then you shift the patient from LMWH to warfarin. Okay, and usually this happens around 5th to 7th day. Okay, so you shift the patient from low molecular weight heparin to warfarin on usually on 5th to 7th day, but it again varies from person to person depending on how much control has been occurred by the use of warfarin. What is the PT-INR level which has been reached? Okay, so this is about this particular question. Right, now let us move on to the next question. Treatment of choice. Just a minute, guys. So what is the treatment of choice for malignant tracheoesophageal fistula? So what is the treatment of choice for malignant tracheoesophageal fistula? What is the answer to this particular question? So what is the treatment of choice for the malignant tracheoesophageal fistula? Anybody? A very simple question. What is the treatment of choice? So Yogesh, Sanjana? B. Very good. So answer is in fact B. What is this? This is a self-expandable metallic stent. Okay. So what is this? It is a self-expandable metallic stent. So how do you use it? See, understand one thing. What is happening in here? You are having a malignant tracheoesophageal fistula. So what is a malignant tracheoesophageal fistula? Let's say if you have a esophageal carcinoma, so what has happened? The esophageal carcinoma has grown and it has eroded into the surrounding trachea. So what has happened? There is a fistulous communication between the esophagus and the trachea. So this is what you understand by the malignant tracheoesophageal fistula. So how do you manage this? You go for a self-expandable metallic stent over here, and usually you prefer a covered self-expandable metallic stent. So what do you prefer? You prefer a covered self-expandable metallic stent. Okay, so what do you prefer? You prefer a covered self-expandable metallic stent, and this is the treatment of choice for malignant tracheoesophageal fistula. So this is a image of a patient with a this is an image of self-expandable metallic stent. So you can see this is a self-expandable metallic stent. Is it a covered or an uncovered stent? So this is basically an uncovered stent. Okay, so this is not a covered stent. Okay, just a minute, guys. Just give me a couple of minutes. Okay, so this is basically an uncovered stent. Okay, so if you have a coating over it, this is a covered metallic stent, and that is what you use in the management of a malignant tracheoesophageal fistula. Okay, so please remember this. So why do you use a self-expandable metallic stent? So another reason or another place where you use it, it is to give a palliative treatment. Now what is a palliative treatment? Because you know that you are not able to manage this particular patient because of the metastasis or something like that. So that is why you have to go for a palliative treatment. Why palliative treatment? So that the dysphagia is kind of overcome and you are able to establish whatever the life the patient has, that the patient should live in peace. And for that you have to provide some benefit. I mean, you have to make the life of the patient bit easy. And you can, how you can do this? One of the major symptoms of esophageal carcinoma is dysphagia. You can try to overcome that dysphagia with the help of this self-expandable metallic stent. Okay, so this is basically used for the palliative treatment, but yes, it is also treatment of choice for malignant tracheoesophageal fistula. So thank you so much for joining me today. Today I covered in a very fast manner. These are the 14 MCQs we discussed in, let's say, half an hour. I hope at least some part of this was helpful to you. If it was helpful, please follow me on Unacademy. You will find the link below in the description box. And I'll just talk a bit about our Plus subscription. Today is our last day of the offer. We are offering our Plus subscription at 999 rupees for 1 month. And today is the last day. So just take a couple of minutes to understand what exactly are we doing in here so that you can decide for yourself. Okay, so you will get a subscription of 999 for 1 month if you use my promo code, that is Dr.Pawan. That is in the description box. How it may help you? I'll just tell you. So we started with the medical marathon on, let's say, 15th of November. This will be continued till 15th of December. So from 15th of November to the 10th of December, what we are doing is every educator is coming and discussing their individual subject in a comprehensive manner. From the 11th till the 15th, what is going to happen is we are going to discuss around 500 MCQs daily. So it will be around 2500 MCQs in the period of 5 days. Okay, right. And what I have done is I have come up with a revision course in general surgery. And in this, what I'm doing is I'm revising the entire general surgery in 20 sessions. I've already covered around 5-6 sessions. You can have a look at them. And you can just go to my page, which is, the link is in the description box. You can go there. You can just have a look at the sessions. And if you find those helpful, you may go for it. So I've divided surgery in a small parts: hepatobiliary, GIT, general surgery, and basically the urology. And there are 4 special sessions. So one of the sessions is, it will cover all the important classification systems anywhere in the general surgery. 2 sessions will be dedicated to all the image-based questions, and 1 session will be dedicated to all the opponents, let's say the triads, surgeries, all those things. So this is how I'll be revising general surgery in here. If at all you feel that this might helpful to you, today is the last day of the offer. We are offering it at 999 rupees. And you can use this promo code Dr.Pawan. What is happening here is you will get the unlimited access to any video. So this is about just my course. You will get unlimited access to any other course. So you can kind of handpick. Okay. So if you have a doubt in some particular chapter for some particular subject, so you can just go and take that particular session. Okay. So that's up to you. So you will have unlimited access. It's up to you how much you have to use. It is only 999 bucks, not much. So if you want, you can just come and join it. That's fine. Now, if you join it, you don't join it, I completely get it, because the main crunch is the time. I just want to convey one thing to you, that please stay calm, because this is very, very important. Because at this time, there must be a lot of pressure. What will happen in the exam? How much rank I will get? Will I be able to do it? Will I be not able to do it? But it is futile to worry about that at this particular moment. What you can do the best is stay calm, and you just can revise. So just revise. And you just need to revise the 80% of the most important topics which have been asked, because those are the ones who are the rank deciders in any exam. Okay, so just stay calm. Don't let the pressure affect your preparation, because the worst thing which can happen is you under deliver in the exam. You have a preparation, but you go into the exam and you do not deliver what you deserve to get. Okay, so this is the worst thing which can happen. I really don't want that to happen to you. So just stay calm and just keep on revising what you have read the entire year. And yeah, you will definitely crack it. Don't worry about it. If you want to use our platform for as a revision strategy or something, I will be more than happy to have you with me. So just go on the page and just spend a couple of minutes just browsing through whatever you want, because today is the last day. From tomorrow this offer won't be there. So tomorrow it will be like 5,000 for 1 month. Today it is 999 for 1 month. So you can use the promo code Dr.Pawan. Even the promo code will be in the description box. And yeah, thank you so much for joining with me today. Thank you so much for taking up time and joining me for the live session. I'm really happy to see so many of you with me. Okay, so have a nice day. Happy studying, guys. And yeah, see you soon. Bye. Hope to see you in the live classes.